It's Dr. Andrew Yen over at St. John's, and we thought we'd take a few moments to go over the management of a challenging issue in hip replacement surgery, and that's specifically the management of a patient after failed treatment for a broken hip. So it's specifically total hip replacement after failed prior treatment of a broken hip. We looked deeply into this problem and even within our own practice, and we published this article in 2020 specifically titled Salvage of Failed Femoral Neck Fracture Fixation with Conversion Total Hip Arthroplasty Using the Direct Anterior Approach. And again, that's a fancy title, but it specifically relates to the management of failed broken hip treatment. So it's important to back up before we go into failed femoral neck fracture fixation and understand that there are two main types of broken hips. So one of the most common one is called an intertrochanteric hip fracture. So this is the trochanteric region. An intertrochanteric fracture goes right through there. Now this area has a very good blood supply, and so this bone can heal. So once the bone is set, often we'll fix this with a rod and screws. The other type of fracture has a very different pattern. That's called a femoral neck fracture, and that's when a hip breaks right through this neck. And there are two main types of femoral neck fractures. There are several classifications, but it essentially boils down to a displaced fracture and a non-displaced fracture. So a displaced fracture will break and then tear all the blood vessels along the length of the neck, and then that will cause the bone in the hip to die. Those patients are immediately treated with a form of hip replacement. What we're speaking to in this paper are when there is a non-displaced fracture, where there's a break through the femoral head, but the blood vessels aren't immediately torn. In those types of fractures, we attempt to save the femoral head by reducing the hip or setting the fracture and then using pins like this to set and stabilize while the bone heals. Now, this is a very effective treatment. It works 90% of the time, but 10% of the time there was just too much trauma at the time of the original broken hip, and 10% of patients will develop something like nonunion, where the bone doesn't heal, or malunion, where it heals but in a rotated or shortened position, or osteonecrosis, like we can see in this patient, where the whole top part of the bone has died, or post-traumatic arthritis, where the cartilage will continue to erode. What makes this situation difficult to treat surgically is that it's considered to be a conversion or almost a type of revision surgery. So patients with femoral neck fractures, almost by definition, have very weak bone. They have retained hardware, which blocks the hip replacement. And these patients are often older and a little bit more fragile. And so numerous steps have to be taken surgically and medically to safely guide these patients through surgery and recovery. So before we go any further, I'll show you how we fix this problem of nonunion or malunion necrosis or post-traumatic arthritis. So the typical sequence is that a patient will have a hip fracture treated with pinning like this. We expect the hip to hurt for 2, 3, 4, 5, 6 months. We become concerned when a patient has prolonged pain after that. Clinically and functionally, what happens is that a patient will actually begin to deteriorate. They'll make some initial gains, but then have a worsening of their overall function. Walking will become more difficult, the leg will get weaker, the limp will become more pronounced. And then when we look at radiographs, we may see healing of the break right through here, but severe changes in the ball above the break, like this type of necrosis. These patients will be unable to bear weight through the hip joint. And so what we'll do is we will reconstruct the architecture or the anatomy through a hip replacement by putting in a new ball and socket that can allow the patient to transfer load during walking or weight bearing. So in our own study, we looked at 42 consecutive patients in our practice who came to us after having failed in situ pinning, and that means putting pins into a broken femoral neck. And these 42 patients had failure with increasing pain, difficulty with movement, and they required conversion total hip replacement over a 10-year period between 2009 and 2019. We look specifically at primary and secondary outcome measures. So primary measures were the radiographic reconstruction in terms of acetabular position, leg length, offset, stem position, as well as other factors with potential complications, including dislocation and periprosthetic fracture. We also looked at secondary outcomes, including estimated blood loss, hospital stay, and functional outcomes at most recent follow-up. The specific technique we used was a direct anterior approach using 2 incisions. Now, historically, this was done through a posterior approach in 1 incision, and this is something that we used to do, but we noted that we had difficulty with the problem of dislocation, and other papers have reported a rate of dislocation between 5 to 20% with this posterior approach conversion hip replacement method. So working with our colleagues, we developed an alternative technique using 2 incisions, where we would make 1 small incision where the pins had originally gone in, remove the pins, close that up, and then go to the front of the hip and then do a formal direct anterior approach. And we did this so that we wouldn't cut any muscle and we would preserve the soft tissues that would maintain the intrinsic stability of the hip replacement. I think it's helpful to look at the demographics of these patients. You can see these are older patients. There was a young patient, but many of these are in their 80s and 90s, and these are often older patients, and the vast majority are women, which is the highest risk group for a broken hip. They're not heavy, they're not thin, and it happens almost equally in right and left hips. Estimated blood loss was about 245 cc's, which is normal for a routine hip replacement. Patients stayed typically 2 nights. Some went home the next day, some stayed a week. And again, these are older, more fragile patients. Many have pre-existing conditions and will need to be monitored closely and may require a longer stay in the hospital. But the vast majority of these patients were able to go home after surgery, and only 6 of the 42 needed to go to a skilled nursing facility or a rehab center. So these patients, even though they struggled after their broken hip for many, many months, were able to become independent shortly after hip replacement. And then at most recent follow-up, they had outstanding function, almost 91 points on their Hoos Jr. scoring system. I'll just take you through how we do this intraoperatively to make sure that the components are in the right place and that we've restored leg length and the appropriate amount of offset to minimize the risk of dislocation, fracture, or leg length discrepancy. So the first thing that we do, and we can see in picture A here, is we remove all the screws because these screws block this stem. Once we remove the screw, we'll make a formal incision in the front of the hip to do a total hip replacement. And then during the hip replacement, we'll use image navigation. And this image navigation is connected to our computer software to give us a precise understanding of our acetabular position, our leg length here, and our offset, which is the distance from the ischial tuberosity to the femur, so that we can create a symmetric reconstruction. And that basically means this side of the hip will look like this side of the hip after surgery. And then at the end, this is what we'll come up with. So this almost looks like a routine hip replacement. And so we can get very precise measurements even in this conversion hip replacement setting, even in the setting of salvage surgery with removal of retained hardware. We took a very close look at the radiographic parameters. Now, a broken hip will often show up as shortened and externally rotated, and these patients were often had a shorter leg either through necrosis or malunion. Their leg was typically 7 millimeters shorter. And And then afterwards, we were able to improve their leg length discrepancy so they were equivalent to within 2 millimeters, which is almost imperceptible to patients. Cup position was precise with at 44 degrees with a 2 degrees of standard deviation, as was acetabular anteversion. So the salvage of these femoral neck fractures is historically been so challenging because all the potential risks, and the 3 major risks could be divided in 2 surgical categories and 1 medical category. So again, these are older, more fragile patients. They've already broken a hip, they've had surgery, they're not improving. 6, 9, 12 months has passed, and they are really struggling with movement and pain control. Surgery is difficult, or converting these, because the historic rate of complications has been pretty high. So the rate of having another fracture in the setting of the conversion hip replacement has been reported to be between 3 to 5%. Most notably, the risk of dislocation can be as high as 5 to 20%, and that risk is so much higher because there's more surgery, there's more scarring, and at the time of the initial injury, the tissue that surrounds the hip is often traumatized. And then finally, it's important to note that these patients are often fragile medically with pre-existing condition, and the historic mortality rate has been up to 23% at 2 years. But I think what we found in this series, by using this alternative technique, we were able to reduce all 3 historic complications to a minimum. And this thereby becomes a potentially safer alternative in this difficult situation. It does mean that we're making 2 incisions rather than 1 big incision, and it also means that we're just doing 1 surgery, not 2 surgeries to remove the hardware and a second surgery to do the hip replacement, because we're trying to minimize the amount of anesthetics. And we found that the anterior approach has been extremely helpful in removing hardware, visualizing implant position, and reducing postoperative issues of dislocation and fracture risk. So treatment of femoral neck fractures is most often successful. And again, when we're dealing with patients who had minimal displacement with an attempt to try to save the femoral head with screw fixation, we mostly see success and results. But we will also see a small subset, up to 10% of patients, who will continue to have pain and may have increasing pain despite successful prior treatment. And this is just because there's been too much damage to the biology, leading to either non-union or necrosis or arthritis. These patients carry much more risk. They often have a lot of atrophy, they're older, they're more frail, but surgery and improvement are still possible, and that we found that conversion total hip replacement can restore very significantly and improve quality of life. These procedures, we know, still carry a significant amount of risk, but I think this series of 42 patients highlights the potential alternative approach to conventional techniques for these high-risk patients. Thank you. So our specific paper goes into far more detail if you want to go down this rabbit hole. It was published in Hip and Pelvis in the summer of 2020, and you're welcome to look that up. Just look it up on Google Scholar or PubMed, and you'll be able to download this through the open access agreements.